Hello, my name is Ioana Nicolau, and I'm from Toronto, Ontario. And I'd like to acknowledge that this land on which I have the privilege to live and work is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I'm delighted to present at CAR on behalf of my co-investigators, the burden of cancer among people living with HIV in Ontario. This is one part of a much larger study called the CARE HIV study, which also examines the role of engagement in HIV care as a potential tool to reduce cancer risk. With the introduction of combination antiretroviral therapy, there has been a decrease in the incidence of AIDS-defining cancers. However, some studies have shown an increase in the incidence of non-AIDS-defining cancers, particularly those that are caused by infectious agents. There are a few studies from Canada and none so far from Ontario looking at the burden of cancer, which is why we wanted to estimate the incidence and period prevalence of cancer among adults living with HIV in Ontario in order to be able to inform local cancer planning and prevention strategies. We designed a population-based retrospective cohort study, which was conducted at ICES. We used multiple administrative data sources, which include the Ontario Cancer Registry and the Ontario HIV database. We included adults age 18 years or older, and in order to identify individuals with HIV in administrative data sets, we used the CASE algorithm, defined as 3 physician billing claims for an HIV-related visit within 3 years. The follow-up for the study was from 1997 to 2018. Our outcome was first primary cancers, and we classified cancers into 4 categories: AIDS-defining cancer, infection-related non-AIDS-defining cancer, infection-related cancers, which is a cumulative of group 1 and 2, and infection-unrelated cancers. We calculated age-standardized incidence rates per 100,000 person years by direct standardization and using the 2011 Canadian population as the standard. We also stratified by sex and calendar period. We estimated limited duration prevalence by calculating the number of people alive on January 1st, 2019 who had a cancer diagnosis in the past 2, 5, and 10 years. We chose these time periods because they align with specific healthcare needs. For instance, in the first 2 years after a cancer diagnosis, there likely is a need for primary cancer treatment services and supportive care for treatment effects. In the following 5 years, there is a need for clinical follow-up for recurrence. And then during the 10-year period, there likely is a need for interdisciplinary healthcare. In total, we included 17,576 individuals in our study. The median age at baseline was 37 years. 78% of individuals were male and 22% were female. 96% lived in urban centers and 62% had moderate to high comorbidity burden at baseline. About 2/3 of individuals were Canadian born and about 1/3 were immigrant born, of whom about half were born in a country with a generalized HIV epidemic. In total, we had almost 167,000 person years of observation, during which there were 1,127 first primary cancers diagnosed. About half of the cancers were classified as infection-unrelated cancers, and about half were infection-related. 29% were AIDS-defining cancers, and 24% were infection-related non-AIDS-defining cancers. When looking at the cancer distribution by sex, we saw that females had a higher proportion of infection-unrelated cancers at 64%, whereas males had a higher proportion of AIDS-defining and infection-related non-AIDS-defining cancers than females. The top 5 most common cancers among females were breast, non-Hodgkin lymphoma, genital, lung, and thyroid cancer. And 4 out of those 5 were also top 5 cancers among females in Canada and Ontario. The top 5 among males were non-Hodgkin lymphoma, Kaposi sarcoma, prostate, lung, and anal cancer. And 3 out of those were also top 5 among males in Canada and Ontario. In this figure, I'm presenting age-standardized incidence rates per 100,000 person years on the y-axis and calendar period on the x-axis. I'm also comparing overall cancer incidence among people with HIV to that of the Canadian and Ontario general population. As you can see, the solid blue line at the top shows the overall cancer incidence trend among people with HIV, which has been decreasing from about 1,100 to about 760 per 100,000 person years. And again, that's depicted in the solid blue line. The lines underneath are the Canadian Ontario general population cancer statistics, and they have been relatively stable at around 500 per 100,000 person years, which is lower than the cancer incidence among people with HIV in Ontario. In this figure, I'm showing overall cancer incidence again as in the previous figure, but here I've also grouped cancers into infection unrelated and infection related cancers. As you can see, incidence rate of infection unrelated cancers has been relatively stable at around 500 per 100,000 person years. And the incidence of infection-related cancers has been decreasing from about 600 to 270 per 100,000 person years, which is shown in the dotted orange line. In the next figure, we focused on infection-related cancers to see what was driving the downward trend by separating infection-related cancers into AIDS-defining cancers and infection-related non-AIDS-defining cancers. The dotted orange line is the same as in the previous figure, but now we added the solid orange line, which shows the decrease in incidence of AIDS-defining cancers from 400 to 100 per 100,000 person years, which follows a similar slope as the incidence of all infection-related cancers. The dashed brown line underneath shows the incidence of infection-related non-AIDS-defining cancers, which seems to have decreased only slightly in the last calendar period to 168 per 100,000 person years, but has otherwise remained stable in the previous calendar periods. The last figure depicts sex-specific cancer incidence rates, where we see that cancer incidence among females in the solid red line seems to surpass cancer incidence in males in the dashed blue line by 2016-2018, although the confidence intervals do overlap. In terms of cancer prevalence, at the end of follow-up, we had 14,896 individuals, and 1.1% of them had a cancer diagnosed in the past 2 years and were likely undergoing some kind of cancer treatment. 3.1% had a cancer diagnosed in the past 5 years, and some could require routine follow-up for cancer recurrence. And 5.5% of individuals, or 824 individuals, were long-term cancer survivors. Just to compare, the 10-year cancer prevalence is 2.4% among Canadians and 2.7% among Ontarians. In summary, we saw that there was a general decrease in cancer incidence over time. We also saw that there was a large decrease in AIDS-defining cancer incidence, and this is consistent with what we know from previous studies. We saw a decrease in infection-related non-AIDS-defining cancer incidence in the later calendar period, 2016-2018, and this is not consistent with what some other studies found in other jurisdictions. We also saw a higher cancer incidence among people with HIV than the national provincial cancer estimates, and this is consistent with other studies who have shown an increase in cancer risk among people with HIV when compared to the general population. This was a large population-based study in Ontario, and it was the first to look at the cancer burden among people living with HIV in Ontario. It used high-quality administrative data and a comprehensive cancer registry. We had a long follow-up period, and also we had a large number of cancer cases, which allowed us to group cancers into 4 different categories. Unfortunately, we did not have information on known common cancer risk factors, but we do have cohort data linked at ICS to administrative data, and this is part of the larger CARE HIV study. We also did not directly compare cancer rates to the general Ontario population, but again, these findings are going to be analyzed in the next phase of the CARE HIV study. We also had a limited number of cancer cases among females, which made stratification by sex challenging. I'd like to acknowledge the contribution of people living with HIV, the PI and all the co-investigators of the study, the community advisory board members, and my colleagues at the Estimate Lab. I'd also like to acknowledge the funding partners and stakeholders of the CARE HIV study. Thank you for listening.